So good day to all colleagues and the distinguished panel of speakers. And thank you very much for inviting me to provide some closing remarks on WHO's perspective and future role in salt iodization and salt reduction. In the past 2 hours, the speakers have shared some very useful information about the current iodine status of populations, the sustainability of salt iodization, and the compatibility of salt reduction and regarding low sodium salt. Now, salt iodization is one of the most important and successful public health programs of our times, no doubt about it. And similarly, salt reduction is one of the most cost-effective dietary risk factor interventions contributing to reduction in CVD mortality and morbidity. Now, prevention and control of non-communicable diseases, including cardiovascular disease, is one of the flagship priorities of WHO Southeast Asia region. And preventing and managing cardiovascular disease and hypertension is an essential component of that priority. And because it all contributes to almost a reduction of 1/3 of deaths from NCDs and 70% of premature deaths in Southeast Asian countries, which is due to cardiovascular disease. Now, the WHO recommendations you all heard from all the speakers are very clear: to reduce individual salt consumption to less than 5 grams a day or 2,400 micrograms of sodium per day, and to increase potassium through increased consumption of fruit and vegetable. So the WHO guideline is very clear. It says the increase of potassium is through diet. This doesn't mean that salt substitutes are not okay. It's just that the evidence for potassium was mostly from the increased consumption of fruit and vegetables. WHO's message is also very clear that salt intake must be reduced, while whatever salt that's consumed must be iodized salt. And this is what we promote across the region. The key point is that both salt iodization and salt reduction programs are equally important. And we saw that there's much more to ensure universal salt iodization coverage, and there's a lot more work to be done in that area. Similarly, there's a lot more work to be done, or rather, work on salt reduction is just starting. And these can and must exist together. And to ensure that both programs are not jeopardized, WHO promotes good coordination and integration between the IDD control and the national salt reduction programs in terms of communication to public, coordination with industry, protocols for evaluation and regular monitoring of population salt consumption levels, and population iodine and salt iodization status. And WHO will continue to support countries in these efforts. And one example is the STEP survey, to which now we regularly add the component of monitoring salt intake through spot urine. And just to add to what Kathy said, in most of the STEP surveys, we also advocate a component of 24-hour urine collection, though it is not always done depending on the country context. In Southeast Asia, populations consume almost double or more of the recommended levels of salt. And while all countries in the region have policies that committed to policies to reduce population salt intake by a relative 30% by 2025, the progress has been very slow. And most countries are at the moment off track on reaching this target. Countries have all committed to either regulatory policies, which include labeling, reformulation, as well as changing or reducing salt intake in institutional settings, and public communication campaigns. And some countries are already started this work and carrying on this work, but much more effort is needed. Salt reduction interventions are best tailored to the local context. One of the problems we see in this region is that majority of the salt consumed is during food preparation or in out-of-home foods, say street foods and sort of market stall foods and restaurant foods, and also the discretionary table salt. And that makes reduction efforts a lot more, I would say, more complex and difficult than just reducing the salt in processed packaged foods. So all these actions have to go hand in hand. Even in this part of the world, the processed food consumption is increasing gradually, and therefore the regulatory aspects have to be implemented while we also address the issue of discretionary and added salt. And this brings me to the aspect of low sodium salt. Now, low sodium salt, I'm sure has a role in sodium reduction, but have to be one of a menu of structural and educational strategies to reduce salt intake. Low sodium salt does not mean that people can continue to use the usual quantities of salt. Low sodium salts have up to about 60 to 70% sodium, and the messaging has to be very clear so that people understand that they have to reduce overall salt consumption, even if they consume low sodium salt. People's preference for salt taste has to be adjusted, since it's the salt taste that drives them to consume more and more salt. Overall salt reduction also has other benefits in terms of reducing the amount of food consumed, like reducing the portion sizes consumed, because salty taste usually has an influence on driving food intake. And also, of course, iodization, if in the future there's more low sodium salt, the iodization issues also need to be addressed. Now, WHO will be providing new guidelines on low sodium salt substitutes soon, and also continue to support the countries on both salt iodization and salt reduction efforts. And I would like to really congratulate the organizers and panelists of this webinar, because I think this is very useful and a timely discussion, because as the countries move forward on salt reduction and continuing salt iodization, there needs to be a lot more conversation and coordination between these two groups, not only at government level, but even other stakeholders, agencies at regional level and at country level, in order to ensure that both programs are successful. Thank you very much.
Thank you, Angela. Thank you for all your